Okay, so this is the second part of the hypertension lecture, and I will be discussing risk factors. So first is age. Your systolic rises progressively with increasing age, although the diastolic may decrease with age. After age 50, the systolic blood pressure greater than 140 is a more important cardiovascular risk factor than diastolic. So that's kind of good to remember that systolic over 140 is a more important risk factor than the diastolic blood pressure. Next is alcohol. Excessive alcohol intake is strongly associated with hypertension. Moderate intake of alcohol has cardioprotective property. Males with hypertension should limit their daily intake of alcohol to 2 drinks per day and 1 drink per day for females with hypertension. Tobacco use. Smoking tobacco greatly increases risk of cardiovascular disease. People with hypertension who smoke tobacco are at even greater risk for cardiovascular disease. Diabetes. Hypertension is more common in diabetes. When hypertension and diabetes coexist, complications such as target organ disease are more severe. Then there's elevated serum lipids, which has to do with hyperlipidemia, and then excess dietary sodium. Excess in dietary sodium is a risk factor, and gender is as well. So hypertension is more prevalent in men in young adulthood and early middle age. After age 64, hypertension is more prevalent in women. So we'll continue on risk factors. Family history. So history of a close blood relative, parents, siblings with hypertension is associated with an increased risk for developing hypertension. Obesity, ethnicity. So I did talk about this a few slides ago. Incidence of hypertension is 2 times higher in blacks than in whites. So that's important to remember. Again, I addressed a few slides ago to look into your book. At that box in your book, I indicated the page number, so please refer to that in your book. I can't stress that enough. It's important as nurses in the healthcare field to be aware that different ethnicities or racial backgrounds do have a higher incidence of hypertension. Next is sedentary lifestyle. So a regular physical activity can help control weight and reduce cardiovascular risk. Physical activity may decrease blood pressure. Socioeconomic status is a risk factor, so it is more prevalent in lower socioeconomic groups and among less educated. And lastly is stress. So that is another key risk factor. A patient that may have a stressful job or is dealing with a stressful family situation, you tend to see their blood pressure being more elevated. So, of course, if they have multiple risk factors, that certainly puts them at a higher risk of developing primary hypertension. So here's a question. While performing blood pressure screening at a health fair, the nurse counsels which person as having the greatest risk for developing hypertension. And it is a 56-year-old man whose father died at age 62 from a stroke. So we're thinking here, this is a history of a close blood relative with hypertension is associated with an increased risk for developing hypertension. Atherosclerosis is the most common cause of cerebrovascular disease. Hypertension is the major risk factor for cerebral atherosclerosis and a stroke. So if somebody does not have that they have high blood pressure, it's not being controlled, that's a big risk factor for developing a stroke down the road. Alright, so then we'll go into the pathophysiology of primary hypertension, and the first thing we'll talk about is genetic links. So with that, different sets of genes may regulate blood pressure at different times throughout the lifespan. So as you can see in this slide, children and siblings of persons with hypertension should be screened and strongly advised to adopt healthy lifestyle to reduce their risk of hypertension. So be aware of that genetic link. Education is key. So certainly it's important to do a thorough assessment, ask a patient about their family history, and if there is hypertension in the family, that there does need to be some close eye on the patient, additional screenings and whatnot to keep a close eye on them, considering the genetic links. Another talk about pathophysiology would be the water and sodium retention. So excessive sodium intake is linked to the development of hypertension. Although most people consume a high sodium diet, only 1 in 3 will develop hypertension. And I shouldn't say it as only, because 1 in 3, that's quite a big number to look at. So with somebody that is consuming a high sodium diet, to further assess them for hypertension. And of course, teaching these patients that do seem to have a high sodium diet to do education on different food options for them that could keep them away from a high sodium diet. So it may be a lack of education. They might not know that what they're intaking does have a lot of sodium in. So a lot of teaching there, having them read the food labels to know that, oh yeah, this actually does have a lot of sodium in it, I should stay away from it. So again, a lot of teaching here. Link among salt intake, blood pressure, and heart changes. So high dietary salt intake exerts hypotropic effects on the left ventricle. Ventricle fibrosis can also result from high salt intake through mechanisms mediated by the renin-angiotensin-aldosterone system. So here you can see high dietary salt intake, and then it goes in, increases blood pressure, increases intravascular volume, etc. Whereas that can cause ventricle hypertrophy, ventricle fibrosis, which are things that we don't want to see. So stress and increased SNS activity, It has been long recognized that blood pressure is influenced by factors such as anger, fear, and pain. Physiologic response to stress, which are normally protective, may persist by pathogenic degree, resulting in prolonged increase in SNS. Increased SNS, which again, remember that's the sympathetic nervous system, just as a reminder what SNS is. But increased SNS stimulation produces increased vasoconstriction, increased heart rate, increased renin release. Increased renin activates the RAAS, leading to elevated blood pressure. And then this talks about the RAAS. So altered renin-angiotensin-aldosterone system. So it has been long, increased renin activates the RAAS, leading to elevated blood pressure. Elevated blood pressure would normally inhibit release of renin. It does not occur in the majority of patients with hypertension. Then there's the insulin resistance and hyperinsulinemia. Defects in glucose, insulin, and lipoprotein metabolism are common in primary hypertension. And then the endothelium dysfunction. It is recognized as a marker for CVD, including primary hypertension. Hypertension can persist as a prolonged vasoconstriction response or as reduced vasodilator response. So as you can see here, an elevated endothelium equals to vasoconstriction. So again, I'm just going to move through this case study. So clinical manifestations with hypertension. You might hear the term as silent killer. Symptoms of severe hypertension: fatigue, dizziness, palpitations, angina, and dyspnea. Those are all some symptoms of severe hypertension, so some symptoms to be aware of. Hypertension is often called the silent killer because it is frequently asymptomatic until it becomes severe and targets organ disease occurs. So complications. So this goes into target organ disease, occurs most frequently in heart, brain, peripheral vascular disease, kidneys, and eyes. So again, with some of the specific complications, hypertensive heart disease, cerebrovascular disease, peripheral vascular disease, nephrosclerosis, and retinal damage. This is a picture of hypertrophy. So the top picture of the heart demonstrates compensation hypertrophy of the left ventricle muscle to pump against increased systemic vascular resistance caused by hypertension. So as you can see here, this is the ventricle that's hypertrophy. So compared with the bottom, which is normal thickness. So as you can see here, there's a lot more, which is increasing the cardiac workload, which is increasing the patient's blood pressure. So next we'll go into is diagnostic studies. So here's a list of the diagnostic studies. Measurement of blood pressure is essential in assessing and monitoring hypertension. There are some controversy as to what the diagnostic workup should be in the initial assessment. Basic lab studies are done to identify or rule out causes of secondary hypertension, evaluate target organ disease, determine overall cardiovascular risk, or establish baseline levels before initiating therapy. A routine urinalysis, BUN, and serum creatinine levels are used to screen for renal involvement and to provide baseline information about kidney function. Blood glucose levels assist in the diagnosis of diabetes. A lipid profile may be done to provide additional information of risk factors that lead to atherosclerosis and CVD. Uric acid levels may be done. An ECG is really important as this provides baseline information about cardiac status. It can also identify the presence of a myocardial infarction or cardiac ischemia. And then if the patient's age, history, physical exam, or severity of hypertension points to a secondary cause, further diagnostic testing is indicated. So this talks about ambulatory blood pressure monitoring. This is a non-invasive, fully automated system that measures blood pressure at preset intervals over a 24-hour period. The equipment includes a blood pressure cuff and a micro-pressing unit that fits into a pouch worn on a shoulder strap or belt. Tell the patient to hold their arms still by their side when the device is taking a reading. Also ask them to maintain a diary of activities that may affect the blood pressure. Just moving through the case study here. Talks about lifestyle modifications would you recommend to control CS's blood pressure. So some of these could be weight reduction, exercise, dietary changes, stress reduction, and smoking cessation. So overall goals include achieving and maintaining goal blood pressure, reducing cardiovascular risk and target organ disease, and lifestyle modifications directed towards reducing the patient's blood pressure and overall cardiovascular risk are indicated for all patients with pre-hypertension and hypertension. I'm going to pause here, so and then I'll resume at lifestyle modifications.